Dr. Lima Sayami. আসে নাই তো এখানে
So both were similar angiographically but treated differently based on IVA's report. The first case presented with post-MI angina with reduced ejection fraction of 44%. The second case also presented with chronic stable angina for last 6 months with no regional wall motion abnormality and ejection fraction was 60%. You can see the angiogram of both patients. Both patients, left main was normal and LAD has disease from the ostium up to the mid part, while SAC is disease in the first case and there's only intermediate lesion in the SAC in the second case. So we took IVAS. In the first case, the LAD has disease from the mid part up to the ostium. This is the ostium, but the polygon of confluence and distal left main do not have any disease, and the SAC also had a tight lesion in the mid part, but the SAC ostium and the POC and left main distal was free of disease in the first case, while in the second case the LAD from the mid part up to the ostium and left main had disease and there's no safe landing zone. Also the SAC, which was not angiographically significant disease, appeared to have a significant disease in IVAS. So this is the first case, the left main both angiographically and IVAS didn't have disease. The LAD ostium has disease from the ostium up to the mid part, and the SAC mid has disease, but the SAC ostium didn't have any disease. And the second case, there's disease in the left main throughout the left main, and the LAD ostium up to the mid part had disease with the MLA of 2, and the SAC also disease from the ostium up to the mid part. So in the first case, we first stented the SAC mid and with a 316 stent. For PCI to LAD, we applied a new technique. We took the IVAS catheter in the SAC and placed the second marker of the IVAS in the ostium of SAC with the idea that it will visualize exactly the position of LAD ostium, and when the stent is inflated, we can proper position it and we can visualize, here we can visualize the stent in the LAD ostium. You can see the stent struts is inflating circumferentially, and it will prevent the plaque shift better than the wire alone. If there is plaque shift, it will be recorded, and it will also prevent to and fro movement of the stent in the LAD. So this was the procedure. We took the IVAS catheter in the left in the SAC and we recorded. You can see the circumferentially placed stent strut in the LAD, and this is after post-dilatation view. There was no stent strut into the left main distal. So we took view after stent placement, and stent in the SAC and LAD were well apposed, and the area of 5.6 was achieved in distal LAD, and 9.6 was achieved in the proximal LAD. And this was the final result. So in the second case, as the left main, LAD and SAC all has disease, so we planned for decay crush. But there was a size mismatch between the left main and LAD, so we treat the LAD as the side branch. We first stented it with 2.75 48 millimeter stent, then did the crush with 4010 balloon, and then did the pot crush rewire, and did the first case, then stented left main to SAC with 4 into 38 millimeter stent, and again did the pot, then a sequential casing, and then did the final pot, and this is the final picture. So we took again the pullback from left main, from LAD and suck to the left main and Steinway will up post. So the learning points is crossover stenting is considered a reasonable treatment from osteal LED lesion, but there is a risk of restricted flow to the circ and stent malapposition in the left main may cause stent thrombosis. But to place the stent exactly in the ostium of the LED is challenging because of geographical miss or excessive protrusion. So IVUS can help, and we have tried a new technique here. In the second case, we first planned from angiogram that we'll do a crossover technique, but after doing the IVUS, as there was disease in the sac left main, so we planned for decay crush technique in the left main because ESC guidelines states that decay crush technique is preferred over provisional one-stent strategy. Here there was a mismatch between left main and LED distal dia, so we first stented the LED. So our decision shapes others' destiny, so we should look before we leap and just put a stem. Thank you all for patience hearing.
Thank you, Dr. Lima.